Good evening, everyone. Today we are going to study the SGLT use of SGLT2 inhibitor in heart failure patients. So SGLT2 inhibitors are associated with 30 to 35% lower risk of hospitalization for heart failure. Now, means why? Means what is the mechanism of action behind it? So we'll see one by one. It has a diuretic plus antihypertensive effect. So SGLT2 inhibitor causes the osmotic diuresis due to glycosuria and natriuresis. Then the next mechanism of action is it helps in weight reduction and improved glycemic control. So the weight reduction and improved glycemic control provides the cardioprotective effect of SGLT2 inhibitor. Weight loss from SGLT2 inhibitor therapy occurs due to increased glucagon-insulin ratio, causing increased lipid mobilization. Then it also helps in increasing hematocrit. SGLT2 inhibitor is associated with the increase in renal erythropoietin production, red blood cell mass, and hematocrit. Now, other mechanism of actions are it has altered adipokine regulation. That means it is suppressing the production of leptin from adipocytes. Because of the reduced serum leptin, there will be the reduced epicardial fat. Then it will improve the autophagy induction because of the increased glucagon and insulin ratio due to increase in urinary glucose excretion. There will be the activation of SIRT1, AMPK, then hypoxia-induced factor, and 2-alpha. Then that it will cause autophagic clearance of damaged organs, and it will the result of it will be the reduced oxidative stress and inflammation, and it will improve the overall cardiovascular health. Then ionic homeostasis. So what exactly they are doing is they are reducing the intracellular sodium and restored sodium calcium exchanger function, and then improve the intravascular calcium concentration and cardiac contraction. Then the next mechanism of action is improved myocardial energetics. So the increased catabolism mimic the state of fasting due to increased urinary glucose excretion. Then it will cause the increased ketone body production, altered fuel instead of the fatty acid and glucose, increase ATP production, because of which there will be the improved cardiac work. Now there are two trials which are published in NEGM regarding the use of SGLT2 inhibitor in heart failure patients. So the first trial is the DAPA trial. In uh, this this is actually a phase 3 trial. It's a placebo-controlled trial. In this, they randomly assigned 4,744 patients with NYHA class 2, 3, and 4 heart failure and ejection fraction of 40% and less to receive either dapagliflozin at a dose of 10 mg once daily or placebo in addition to the recommended therapy. And the primary outcome was composite of worsening heart failure or cardiovascular. And the result of this study is primary outcome occurred in 386 of total 2,373 patients in a dapagliflozin group, and in 502 patient of out of 2,371 patients in placebo group. So the first worsening of heart failure occurred in 237 patients in dapagliflozin group and in 326 patients in placebo. So as we can see, the number was less in the dapagliflozin group. And the death from cardiovascular causes occurred in 227 patients in dapagliflozin group and 273 patients in placebo group. 276 patients and 229 patients respectively died from any cause. Okay. So as we can see from these readings, the death from cardiovascular cause was less in dapagliflozin group, and as well as the means worsening of heart failure was also less in dapagliflozin group. So the final conclusion was the risk of worsening of heart failure and death from cardiovascular cause was lower among those who received dapagliflozin. Then the next trial is Emperor trial, which was again published in NEJ. It is also the double-blind trial, which randomly assigned 3,730 patients with class 2, 3, and 4 heart failure and ejection fraction of 40% or less to receive empagliflozin 10 mg once daily and placebo. The primary outcome was composite of cardiovascular death or hospitalization for worsening of heart failure. And the result was primary outcome occurred in 361 patients out of 1,863 patients in empagliflozin group and in 462 patients of 1,867 patients in the placebo. And the effect of empagliflozin on primary outcome was consistent in patient regardless of the presence and absence of diabetes. The total number of hospitalization for heart failure was lower in empagliflozin group than in placebo. The annual rate of decline in the estimated GFR was slower in empagliflozin group than in placebo group. And empagliflozin treated patient had a lower risk of serious renal outcome. Complicated genital tract infection was reported more frequently with empagliflozin. So, among the patient receiving among the patient receiving recommended therapy failure, those with the empagliflozin group had the lower risk of cardiovascular death and the hospitalization for heart failure than those with the placebo group, regardless of the presence of diabetes. Thank you so much for patience.